Dr. Bajaj, thank you. That was a wonderful overview of the entire spectrum of diagnosis and management of hepatic encephalopathy. I'm sure our viewers will have a lot of questions. So anyone who have questions, please raise your hand so that way we can go in order. And I see that Dr. Najia Kazi has her hands raised. So before Najia, you ask the question, I will ask one question to Dr. Bajaz. Patients with hepatic encephalopathy, you convinced us that they increase the risk of increase the mortality risk in patients who are transplant candidates if they're without a transplantation. Why we so far have not been able to get a MELD exception for these patients who are especially with the recurrent episodes of encephalopathy?
We are a victim of our own success. We lie too much to help our patients. When the CTP score changed to MELD, overnight, grade 3 and 4 encephalopathy disappeared for these patients. We had done that study in 2002. What is happening is right now if we need to make this happen, we wrote a review 2 years ago in Liver Transplantation about the disparities of HE in patients, why we are not, and which we had pros and cons. I didn't have time to go over that. The pros of using HE, the cons of using HE, and what are the ways we can actually make sure that the HE is quantitated so that you don't have to go to a national board every time. But suffice it to say, there is very little appetite within the transplant field to actually put HE as this because of its inherent subjectivity. There are some things in that paper. The first author is Acharya in Liver Transplantation 2022, in which we actually went through the pros and cons of this. Right now, we don't have, like with ACLF, there is very little appetite right now to actually change the transplant schedule. With MELD 3.0, including albumin, etc., there is a hope that hepatic encephalopathy will be taken care of with it. And if you look at the MELD 3.0 analysis, hepatic encephalopathy was not really additive to that. So the hope is, as MELD 3.0 gets more and more traction, the patients with hepatic encephalopathy will hopefully get a better deal than they're getting right now.
Thank you so much. Dr. Kazi, please go ahead.
Thank you so much for this is indeed a master class in the management of hepatic encephalopathy, Jazz. Thanks a lot. So my question is related to the systems design part of the management of the hepatic encephalopathy. So how do you get the other village that you talked about, that is IR, PT, etc., to join us in the management of hepatic encephalopathy? How do we incentivize them, or do you have any thoughts on that?
It's all depends on your relationship with certain people. There are certain people in our IR group that I usually go to, and they usually know. And over time, the relationship develops. So you just have to have, especially for the dietitians that we have inpatients. We have an outpatient dietitian and 2 inpatient dietitians, at least in the VA. We treat them as part of the team. Every time I go to rounds, I bring them with me or actually talk to them about specific patients. So they actually are able to be part of it. So as long as they feel like they're part of the team and not technicians for a particular patient, you don't even have to do anything else. This is their job to actually take care of these patients. You just have to make sure that this job gets prioritized over the 5 million other jobs that those people might have. So and there is no point, I think, unlike with HCC, where all of us have to sit together and talk about every patient's HE. What we need to do for this is actually be aware of what resources you have locally versus others so that you can call upon them for specific patients. But to me, the most critical thing is your relationship with the inpatient team. If you are predominantly an outpatient practitioner and you do not have a good relationship, or you don't know who the inpatient teams are that are sending you the candidates, that's where majority of the problems happen, where the patient, so the more in touch you are with the inpatient teams, the hospital medicine specialists, as well as the house staff, those are the people who will actually spend a lot more time with the patients and their caregivers before they're discharged, because that's 90% of the recurrence is nothing related to medical issues. It is related to communication issues.
Thanks. So communication is the key. Thank you very much, Jazz.
Absolutely. Thank you.
Dr. Gupta, Dr. Rohit Gupta.
Hi, Dr. Bajaj. Just a quick question. At the 3-month mark, what assessments are you deciding or completing before you give their license back?
We don't
especially
part one. We don't take anyone's license back as doctors. I don't know how it is in where you practice. Are you back in Australia? I don't know.
Yeah.
So I don't know. In the US, every state is different. But what we really want to know is if the patient has not had a recurrence in the 3 months. And again, this is consensus. This has not been proven by anything. It's just that within 3 months, the chances of recurrence are the highest. And if you can go white knuckle through that and have a steady state with lactose rifaximin, the chances of you getting a recurrence are very low. And hopefully by the end of 3 months, you would know what a recurrence episode feels like, and your family members would know as well. So there are no testings we actually do, but in patients, because this is overt HE, the clinical syndrome trumps any cognitive testing that you might actually give for these patients. What you could do in these patients is to optimize therapy, make sure that they're doing things like the Bristol stool scale and they're taking their medications appropriately. And that ideally should take care of all these other things. We do not take anyone's license away. We just request them quite forcefully to not drive and make sure the patient's family members are around. If they really are the only driver in the family, then we advise them to drive short distances, use GPS, do not use anything that distract them while driving, and not drive at night. Those are the things we end up doing because sometimes that patient is the only person in the family who drives. So there are no hard and fast rules, but we are not policemen. We are not the Department of Motor Vehicles. We can only advise on what to do.
Sure. Thank you.
Thank you so much. Dr. Mohan Gudela.
Good evening, sir. Thank you so much for the opportunity. Am I audible?
Yes.
Yes, yes.
Sir, I'm a critical care medicine resident, and I would like to ask how hepatic encephalopathy is different in acute liver failure compared to cirrhosis. And while managing critically ill patients, acute liver failure patients, what could be the sedation of choice? Does dexmedetomidine actually helps? I would like to know it from you.
So I obviously my topic here focused only on the acute or chronic or patients with cirrhosis as the baseline, but you clearly bring out a good point that acute liver failure, the HE with acute liver failure is much more rapid, and it's much more associated with ammonia and much more, it's a much more of an emergent condition because of the potential for cerebral edema in those patients and them to not being a good transplant candidate. In that, you want to prevent infections. You want to make sure that the patient is actually, their ammonia is lowered as soon as possible, and they be listed for liver transplant. Those are the very big differences compared to hepatic encephalopathy in patients who have acute and chronic liver failure or cirrhosis. The management sedation for these patients, both in acute and chronic liver failure and ALF, the dexmedetomidine is preferred, not because there is anything inherently different about it. It's just that it's slow. It's a very fast method of action. What you don't want is benzodiazepines that are running not in boluses but in continuous infusion, because you need to actually make sure that these patients' mental status is checkable, and many other things that happen, you are able to get the patient's response to it. So ideally, you'd only do it if the patient is agitated or you need to intubate the patient. But if you can get away without intubating or giving sedation, because the mental status in acute liver failure is such a critical aspect of their prognostication, you really should avoid them as much as possible. Dexmedetomidine, as I said, is only because of its short duration of action. That's why it's put in the recommendations for the ACG guidelines.
Thank you so much, sir. I have one more question, if may I ask?
Yes, please go ahead.
Yeah, sir, have we considered non-convulsive seizures in a population of hepatic encephalopathy? Do they actually play a role?
They're very rare. Every time I've actually put that as a potential, they really do not pan out with the EEG. The EEG typically shows those triphasic waves. So if the patient is not responding to HE therapy, and you've given everything that the patient could have, and there's no underlying other precipitating factors, that can be certainly one of the alternatives. But I have personally not seen that as a major contributor.
Thank you, sir. Thank you so much.
Thank you. Dr. Kapoor, Dharmesh Kapoor.
Hi, Sanjay. Happy New Year to everyone. First hepatology session in this new year.
Yes,
And just
thank
that
you.
was a great talk.
Thank
No
you.
questions, but it's just that, my interest in HE is a little different from whatever you've spoken in the last 1 hour. So typically, patients who've got chronic persistent HE,
Yeah.
I think even the phenotypes vary. And that's again something that has not been talked about much in literature. You
And I
these
think
so-called
we should actually do,
Parkinson's,
the hepatocerebral syndrome.
symptoms.
Yeah. And
No,
actually,
outside of the
I did not get a chance to talk about this because, I can go on and on. As you know, I do go on and on. Their microbiota are very different from these other patients. So it's really interesting because, as you know, the Parkinson's with liver disease is very different from usual Parkinson's disease. And we are trying to study why some people get this chronic condition and why some people don't. And you're right on the money that this is actually the most challenging group of people. And that's why the cognitive tests that we do actually ended up being, a lot of them ended up having some Parkinsonian features as well. And there's two case reports that we had published as part of a review in CGH in 2022. There were two people who were actually, it was not clear whether they had cirrhosis or not. From the neurologist perspective, they were treated as Parkinson's or related dementia. So when we saw them as an inpatient, we realized that the patient actually had cirrhosis. We treated them with lactose and rifaximin. They got better. Not the Parkinsonian features, but their brain function. So it is also important, and I'm glad, Sanjay, you have people who are from critical care here as well, for us to get this message that with the old people getting older, you can have a huge overlap between cirrhosis, Parkinson's disease, and dementia with and without Parkinson's. And if you have someone you're assuming has dementia, I can't talk to you about specifically, but on January 31st, we have a paper coming out that deals with it. I'm under embargo, but this is a big problem. Dementia and hepatic encephalopathy overlap, part of which has Parkinsonian features, as Dr. Kapoor correctly pointed out.
And the second thing which is of great interest to me is, you talked about management of hepatic encephalopathy as an inpatient, but hepatic encephalopathy in the ICU, especially those patients who also have some other organs knocked out. Of course, in our country, transplant activity is a little different from the US, perhaps, because you did mention in your talk that the surgeons are not very keen to take on board patients who've got encephalopathy. And again, that is a nuanced topic. One can talk about the pros and cons on that too. And that's the contribution of cerebral edema in patients who have HE in the background of cirrhosis when they are in the ICU, especially with other organs knocked out and including the syndrome of ACLF. So again, this is something which has not been very well spoken about, written about, and also there is a lacuna in the current state of knowledge, I would think so. These
I
were the
agree.
two concerns.
I agree with you. The second point is always very important because every patient is different, every situation is different, whether they can afford or are candidates or have a donor for a living donor. All of these make a huge challenge versus a deceased donor. All the things that we are talking about, I talked about, were related to deceased donors. But when you have a living donor and with the donor already available, all of these things fly out of the window, and then you need to figure out whether any of these people have kind of a brain dysfunction that may not be reversible after liver transplant. And that really and that's why our surgeons become very nervous when people do not wake up after days, because that to them specifies, in most cases, not all, that this patient is going to have a very poor recovery mentally after transplant. That's the reason for my this. And again, this is a case-by-case basis, and that's why it's incredibly difficult to do these trials or do any kind of analysis of this, because every patient is different and every situation is very different. You're correct in that.
Dr. Bajaj, you brought a very interesting point, and I would like to elaborate on this as well. Like post-transplant, after transplant, some of these patients do have episodes of maybe encephalopathy. And we had a case, it's an isolated case, who went home and came back with an episode of encephalopathy, and we found a large splenorenal shunt, and we embolized it, and then since then the patient's doing well. So my question to you is, do you think this might be playing a role? Many of these patients who had splenorenal shunt, they might be playing a major role in their cognitive decline, or maybe covert encephalopathy afterwards. Is that something that your experience is, or do you think your comments on it?
Yes, it clearly does play a role, as you know, because in a patient with persistent encephalopathy, if you actually reduce that, embolize them, patients do feel better. But what we have to realize that, patients, with post-transplant, it's not overnight. None of these changes, if you can have ascites persistent up to like 3 to 4 months after transplant, which means if they had huge splenorenal shunts, they're not going to get better overnight. And post-transplant, we end up stopping the lactulose and rifaximin, which they've been actually used to reduce their, shunting, consequences of shunting. But fortunately, these cases are few and far between in these patients. And some surgeons have a way of actually tying off those things to prevent, quote unquote, the splenic steal. But some surgeons don't, and you just have to individualize it with these patients. But by and large, these cases, if you have a patient who comes in with altered mental status post-transplant, these are much more likely to be de novo impact of either the calcineurin inhibitors or some infection or something else that's going on. That's going to be the majority of those patients. What you describe is fortunately a very rare condition, but it does happen.
Thank you. Dr. Jalal, Usman Jalal.
Thank you, Jess. I will tell you that in 1 hour or less than an hour, what you have presented, no one can do it. It's really, look, no one knows more about HE than Jess and in the whole world. Oh, it's a great achievement. Simple question. I mean, obviously, your work encompasses many areas. Now, rifaximin has done its work. It's great. But what do you think the most practical medication or drug therapy next? How you want to add up to what we have at the moment? I mean, obviously, you outlined a lot of possibilities, but what do you think is the most realistic as a next step so that drug companies or anybody get involved?
Oh my God, that's such a loaded question. You want to break so many confidentiality rules here. I'm not breaking any. I'm not breaking any of them. But I think the frontier right now is to make sure everyone gets the medication they're supposed to get. Instead of going after the next shiny thing, we just have to consolidate our gains. We have enough in the guidelines that can prevent more than 80% of recurrent HE episodes. We just have to do a better job communicating what we have done to people who have other competing priorities, like inpatient staff have multiple other things, and they want to get the patient out, but you need to tell them what all needs to be done gently and firmly and using case reports of what happened. So I think if we focus on consolidating the gains, the multiple gains that we have actually achieved so far, not only in medication therapy, but actually figuring out the prognostication and management of these patients, I think that will actually prevent so much more HE episodes than potentially an incremental advance with a newer medication in the future.
But I don't want you to break any confidentiality. That's fine.
Yes, I did not. It's being recorded, even worse.
Thank you.
Thank you. I have one more question. Okay, Dr. Burma has the question first. Please go ahead, Dr. Raj Burma.
Hello, hi, Dr. Bajaj, Happy New Year, and Dr. Satpathy, Happy New Year to you as well, Happy Lori. The last time I remember I met both of you together was actually 6 years ago when Dr. Satpathy organized the NASH symposium in Memphis. At that time, I had the opportunity to introduce Dr. Bajaj. So, Dr. Bajaj, I am practicing in Minneapolis, and I will ask you a 3-part question, more so on the practical basis. First, the NCEF lab that you were also involved in launching, who is the ideal patient in your practice? You have experienced that NCEF lab is a good app. You know, you need a lot of patient buy-in, patient should be tech savvy, this, that, to use that app. So that's first question. On whom do you use NCEF lab is a good patient? Second, sometimes we see that the patient was cirrhotic and got admitted to the hospital and maybe was little drowsy for whatever reason, but did not have any known diagnosis of hepatic encephalopathy, and the hospitalist had started lactulose and rifaximin. Do you discontinue them in your clinic anytime when it has been started by the hospitalist as an inpatient? And then the third question I have for you, more for US and not for our colleagues who are joining us from India, is as you touched upon the availability of rifaximin, as to how difficult it is to get and how insurance sometimes does not even approve it. So the only two resources that I have found, one is the Mark Cuban's Cost Plus Drugs. And then second is there's a guy in Canada called Planet Drugs Canada who gets the Rifagat, which is available for $450 from Sun Pharma in India, gets it from India, sells it for 3 to 4 times the price. But those are the only two resources I have where my patients can use them. Do you have any other practical resources from US standpoint for rifaximin for our patients? Thank you so much.
Last question first. I don't have any other resources than what you would actually describe for these patients, and whatever you can do to make to be the best advocate for your patient, including getting them from Canada, I think that's good. The middle part is kind of a gray zone, which is when someone starts it. I usually talk to the patients, their caregivers, and go to the chart point by point. If there was something that truly encephalopathy, like when the patient was confused and they did a proper precipitating factor assessment, they found a precipitating factor or dehydration and it got better, I err on the side of continuing the medication and optimizing it, because the risk of actually stopping this medication, especially immediately after hospitalization, is very, very high. This patient could actually get another episode of encephalopathy. What you'll find typically with these patients is they usually stop the medications on their own, and the patients continue to coast if it was truly not an HE episode. Regarding NCEF, I use it in a separate, I don't do it during the same clinic visit. We have a separate clinic that we actually refer these patients to. That clinic takes 20 minutes or so, which we do the medication review, we do NCEF and other things. The NCEF, you want a patient who, because you are giving this to the patient is not doing it at home. You don't need the patient to be very tech savvy. We do it on an iPad, which is relatively bigger for our patients who are mostly 45 plus. You want to make sure that the patient does not have red-green color blindness. If the patient has red-green color blindness, that they are not a candidate for encephalopathy, you want to do something else, such as animal naming tests, etc. And after you're done with the NCEF, if you look at the NCEF, if you download it, it typically comes with instructions. One thing leads to the other thing leads to the other. You can actually change it to what we call the quick Stroop setting. You can make it so that you can get the results in 1 minute instead of actually doing the entire 10 minutes. And you go to the website called encephalab.com, and this is only for the US. These norms are for the United States. If you actually, it has norms for both quick Stroop and the whole NCEF. You put in the age, gender, the sex, the years of education, and the amount of time it took for you to do this. And this patient, it spits out a number whether this patient has minimal hepatic encephalopathy or not. And then what we end up doing is in that same clinic, we actually negotiate with the patient. Should we start you on a low dose of lactulose or not? And we will repeat the testing within 8 weeks to see if your cognitive function actually gets better or not. And we also do the stop bang questionnaire, because what we found is obstructive sleep apnea is really critically prevalent in our patients. So the NCEF testing really should not be done in the clinic. While you're seeing, your clinic should really be consolidating everything, including the endoscopy, including the ultrasound, including the cognitive evaluation for these patients. So I would urge you to actually do this separately, not while the patient is, distracted by a million things in the clinic. It has to be done separately in a quiet area.
Thank you so much.
Thank you. And I have one question, Dr. Bajaj. you mentioned about the relationship of encephalopathy and sarcopenia. So does the treatment of sarcopenia would have an impact in improving encephalopathy? And the reverse also, the question is if the patients with encephalopathy, are they more likely to have sarcopenia?
Yes, yes, and yes. Although the last part of reversing sarcopenia after with encephalopathy has not been actually tested, because it's in this edition of the last edition of the ASLD, there were 3 studies that actually, for the first time, actually made a meaningful change in sarcopenia. One was the study that I just talked to you about with the rifamycin. The second was a study presented by Dr. Sanyal, which is an androgen analog. And the third one was a study presented by a nice study presented by Australian colleagues, in which they had actually done meaningful drainage of the ascites that improved sarcopenia. It remains to be seen if that sarcopenia improvement results in reduction in encephalopathy. But the other way that has been tested is patients who've undergone TIPS and have not had encephalopathy. Post TIPS, people do develop better improvement in their muscle function. And those are the people who ended up having less encephalopathy after TIPS. So right now, the reversal has not been studied to a great extent, but it is quite clear that the more patients who have sarcopenia are much more likely to have hepatic encephalopathy.
Thank you. And one other question on that line. So you have this episodic hepatic encephalopathy, and those who are recurrent hepatic encephalopathy. Now, does an episodic hepatic encephalopathy is a contraindication to TIPS, an elective TIPS in somebody who is having ascites? I think I need to get a clear message to our audience. So.
No, only if the patient does not live alone, has someone to tell you if they have TIPS. So again, you need to find out why the patient is requiring a TIPS. If it's an urgent TIPS, no bets, no questions asked, you need to go ahead and do it. If it's not an urgent TIP, it's an elective TIPS, there is a survival advantage of TIPS over large volume paracentesis, and it is a very personal decision. We have our patients who really do not want a TIPS at all, because if the 20% risk of encephalopathy is too much for them, they are the ones taking care of the entire family. They are the only drivers. So you have to ask the patient in great detail. There is no one size fits all for all of this. But by and large, when TIPS was first introduced, hepatic encephalopathy was an absolute contraindication. As we get to know more and more with the covered TIPS, the encephalopathy has become a relative contraindication in these patients. And in my practice, I do put in TIPS in patients with hepatic encephalopathy, provided their HE is well controlled. They have people in the house who can call us in case they get recurrence again. And then the patients are agreeable to having a TIPS place, which may worsen their encephalopathy, at least temporarily, for the first 3 months post. So yes, encephalopathy presence is not a contraindication per se, but there are many mitigating factors that you need to put together.
And also to that point, TIPS has been also shown to improve the muscle mass sarcopenia as well.
So this may actually end up being a treatment in the longer term.
Yeah. And then it doesn't matter episodic or recurrent, as long as they're well-controlled encephalopathy, you're fine for elective TIPS and managing ascites.
Provided the patient is also agreeable and you ask them.
Okay, that's a very strong statement and important as well for our, practical management of this patient. I think those are my main questions. Does anyone have any other questions?
Something in the chat regarding HE, FMT in HE. I do not know what you want to
Dr.
ask.
Samantha, why don't you ask the question, Dr. Samantha? Are you, Dr. Arghya Samantha?
Because I don't know what you want to know in that. I can speak for 2 hours on this.
Yes, I think. So I think he simply wants.
It's still experimental at this stage, if that's what you want to know.
Yeah.
And larger studies, we've finished one of our studies, and that's hopefully is going to come out. We put it in for EASL.
Okay.
But we need to know. Right now, there are still questions as to number of doses, the route, and who is the ideal candidate for this. But clearly, what studies have been shown is this is safe. It does not transmit infections if you choose the donor and the recipient very well. So this is not a DIY. This is not a do it at home. kind of situation for these patients, because yeah, you can do serious harm to these patients if the current donor recipient match is not put together.
And I think one other question which actually came across when yesterday during one of our selection meeting, actually, one of our patient in the ICU having maybe delirium symptoms, especially in the night. Encephalopathy listed patients. The question that came in, is it truly an encephalopathy or is it a delirium in this patient? Is there an objective measure that can help us distinguish like EEG or something?
Yeah, overt hepatic encephalopathy is a form of delirium. So that's just metabolic encephalopathy that can present in a delirious state. Yes. So the triphasic EEG is the only specific thing that you can do in those patients if the EEG shows that, to show that this is hepatic encephalopathy.
So doing
everything else is a circumstantial thing. In a patient with cirrhosis who comes in with infection, but they can have delirium. A patient with cirrhosis who has alcohol withdrawal, they can have delirium. All of these go into the general bucket of delirium in these patients.
Yeah, but does it? So doing an EEG potentially can help distinguish.
Yes, it can.
This,
yeah,
right?
So it has
right. That's my question.
It has the triphasic wave that can actually help in those patients. Yes.
Yeah. I think we are almost to the end of this meeting. If anyone else has any other last
There's a question
questions.
on carnitine. I have no experience with that because we don't use it here in the United States. But there is some published experience on carnitine. Acyl carnitines have been associated also with HE development with metabolomics. They have been also associated in promoting the growth of Enterobacteriaceae in the recent study. Oral LOLA, very low evidence compared to IV LOLA.
And what about branch chain amino acid? Do you use routinely in
we don't.
practice?
In the US, it is not pharmaceutical grade. So we focus on actually people getting an overall good nutrition with things that increase the protein and getting good nutritional support from these patients.
Thank you so much. I think this is a wonderful discussion and a great talk. And I'm sure those who have not been able to attend today, the talk, we will, with your permission, of course, with Dr. Bajaj's permission, we will upload it in our...
Sodium benzoate. Okay, the sodium benzoate, I don't use it in my practice because of the sodium load. The studies, the prior studies that have been done are much more in the urea cycle disorder. And one nice study that was done a while ago showed benefit. But right now, it's not widely available. The sodium load actually makes me a little nervous.
That's a good point. Again, thank you so much. Thank you everyone for joining. I just want to make one announcement. We're now starting INEDCAST Gut Club. The first session is coming in January 22nd. This will be again every 2 weeks, and I'm not the moderator for this, of course. I'm a hepatologist, so there'll be someone else will be moderating that session. But it is starting, and trainees particularly will find it's very valuable. And the first talk is in IBD and cancer. So there is a separate link for joining. There'll be a recurring meeting, and once you sign, it's going to keep you can keep joining. So look out for those emails, and if you like to register, and be very helpful for learning. And again, Dr. Bajaj, thank you so much. Again, this is wonderful. Thank you so much.
Thank you. Bye.